morning, good evening, wherever you're at. Today's topic is going to be about half-life of pharmaceuticals and what it means and what it doesn't mean. It's kind of a subject that gets misunderstood by patients and even medical doctors. God bless medical doctors. They got enough work on their hands diagnosing disease, so they can't get into the weeds of pharmacology too much, or it would distract them away from their job that they have to do. So, the main point I want to drive home with this quick video is that half-life and duration of action, they're not the same thing. So a drug with a half-life, a long half-life, in many cases it does mean a longer duration of action. So the two are correlated. Obviously, the longer a drug can hang around in your system, the better chance that it's going to extend the duration of action, but not always. And in some important drugs, this isn't the case. Uh, and it boils down to pharmacokinetics, which is it's a complex subject. It's the way drugs, it's what your body's doing to the drug, and we'll get more into that in later slides. And I want to be clear here that definitions are important when we're looking at this subject of half-life, and understanding the difference between half-life and duration of action. It's an important thing for dose regimens and understanding what a drug level in the blood actually means. And we'll get into that, the importance of that on some later slides. So, defining half-life. So when you're hearing about the half-life of a drug, most often what you're hearing or what is listed is the terminal elimination half-life. And what that means is it's the amount of time it takes for your body to clear the drug from your serum, from your blood. It takes time. It's the time it will take for half of the drug to be eliminated from the plasma or the blood. That would be the half-life, the terminal elimination half-life. Elimination. That can be described by simple mathematical formulas. It's a decaying exponential function. However, relying on that is not particularly accurate when you're dealing with drugs, pharmaceuticals, and the complexity of pharmacokinetics and pharmacodynamics. So, some simple definitions. Pharmacokinetics is what your body is doing to the drug. It's how it's metabolizing it. It's how it's breaking it down. It's how it's routing it through to different organs. Pharmacodynamics is what the drug is doing to you, and that's more of a subjective sort of parameter where back in the day they would actually dose people with the drug and see how long it's acting on them. You can take a drug like, and we're going to use diazepam in this example for the rest of this lesson because it's an old drug. It's been studied a lot, and they would maybe give people diazepam and measure how long it took, or what was the duration of action for it to stop basically the effects of the drug. So people's reaction times were measured. They would put them through a routine tests measuring reaction time, balance, and all those things, and they would come up with the amount of time that the drug is actually working on the person. Now, there's a relationship between the two, but the effect of a drug may wear off while the pharmacokinetics are still ramming away. So the effect of the drug can be no longer present, yet your body still has the drug in its system, in the blood, and it's still dealing with it. It's still routing at different places. It's still metabolizing it, and it's still routing it out of the system, either hepatically or most drugs are renally excreted. So if you're looking at half life from a simple standpoint, it's an exponential decay function. And if you know the half life, you can figure out the amount of the drug that's supposedly left in somebody's system with this equation here. Uh, NT NT equals NT equals NO times 1/2 N. So the amount of drug remaining would be NT. NO is the initial dose times 1/2 N as the exponent, and the N would be the half life cycles. So if you had a half life of 24 hours and it's been 48 hours, you would basically have two cycles. So you would plug a 2 in there and solve for your equation. And this equation works very well for precise decay situations, like I said, like radioactive decay, but it's not so hot for calculating drug metabolism. An example of a drug, like I said, we're going to look at diazepam uh, with a terminal elimination half-life that's very long, but a much shorter duration of action is diazepam, otherwise known as Valium. It's a drug that's been around a long time. It's generic. It's been around since the 60s, and we have a lot of studies done on it. So I like to use it as an example for these types of things. It has a terminal elimination half-life of around 60 hours, but it can vary widely between 20 and 100 hours, depending on the individual. Some people with hepatic dysfunction, their liver enzymes aren't kicking out, or there's something else going on. Elderly people tend to clear the drug much slower. It can go up to 100 hours. So I'm going to stick with 60. I think that's the most common sort of average number for a middle-aged person. But diazepam has an actual duration of action. It's much shorter than 60 hours, and that's only one half life. So you figure five half lives, you could be up to 500 hours when looking at diazepam and its active metabolite, nordiazepam. But we don't see those duration of actions. As a matter of fact, when it's used to control seizures, muscle spasms, or even anxiety, you'll see it dosed 2 to 3 times a day because the duration of action tends to only be around 6 to 8 hours, despite this very long half life. And I've heard, clinicians say, well, that drug has an extremely long half life. You should only need to dose it once a day or once every other day. Well, that's sort of a mistake unless you know that the drug has a duration of action of a single day or up to 2 days. There are examples of those drugs. So diazepam is a great example of how volume of distribution, minimum effective dose, uh, lipophilicity, pharmacokinetics, uh, biphasic elimination, first order kinetics, they all come into play when determining what the actual half life of the drug was. So if you were to use that equation I just showed you, the simple half life formula, we introduced a person taking, say, 20 milligrams, a single 20 milligram dose of diazepam, that person would still have uh, theoretically 2,500 nanograms per milliliter in their blood after 3 days. Well, that obviously doesn't happen. That's up at the higher end of the therapeutic scale, and it's also damn near the toxic level. I think 3,000 nanograms per mil is the toxic level. So this would be at that top end of that range, and that doesn't really happen. We know we can dose it 2, 3, even 4 times a day, and not have people reaching those levels. So the reason for that is diazepam follows first order kinetics. Some scientists prefer to say it's a biphasic elimination, and I'll get into what that means, a biphasic elimination, in a minute. But it's highly lipid soluble, so it gets to the brain pretty quick and it exerts its action. But then diazepam, because of its lipophilicity and its high volume of distribution, which we'll talk about a little more in depth, it rapidly redistributes into the fatty tissue in the body. It reaches a kind of equilibrium where it's in the tissue and in the blood. And as the blood level drops, a little more comes out of the tissue to kind of maintain a sort of a slow equilibrium between the two as it works its way down over days. So the initial peak in the blood is followed by a rapid pull down with first order kinetics and biphasic eliminations. You'll get a peak where you hit C max and it comes down pretty quick. So first order kinetics is a system by which the higher the concentration of the drug in the body, the more the body is going to dedicate its resources, its enzymes, its hepatic enzymes to clearing the drug from the system. So it's not like alcohol where it's zero order kinetics. There's more going on here. And like I said, pharmacokinetics with drugs are complex. So, of course, the terminal elimination half-life is indeed long. Diazepam can be detected in the blood for weeks after a single dose, but the level in the blood is, like I said, in equilibrium with the tissue, and the blood levels they get below the minimum effective concentration. So there's a minimum effective concentration that needs to be in the blood or the serum for it to pass the blood-brain barrier. The blood-brain barrier is like a pump. It lets stuff in and it pumps stuff out. And once the concentration in the blood drops below a certain level, not much of that diazepam is making it back through the blood-brain barrier, and it's not having its effects on the central nervous system anymore. The minimum effective concentration, that's the lowest concentration necessary to exert a therapeutic effect. And another thing about diazepam, it has a very high volume of distribution. And we're going to talk about volume of distribution. It's one of the less talked about parameters in pharmacokinetics. So the volume of distribution, it's a little tough to grasp. I remember banging my head against the wall trying to understand exactly what they were talking about with volume of distribution. But you can think of it as a concentration that will be required. It's usually listed in liters needed to maintain that fixed concentration in the blood. So the volume of distribution is a pharmacokinetic parameter. It estimates the apparent theoretical volume of fluid required to contain the total amount of a drug in the body at the same concentration measured in the blood. The lower the number, the greater the volume of distribution. Okay, so I believe off the top of my head, I'm trying to remember. I believe Valium or diazepam has a volume of distribution of 1, whereas lorazepam has a volume of distribution of 3 to 4. So that means Valium or diazepam loves to hide out in the tissue a lot more than lorazepam, which is it's a hydrophilic uh, compound. It likes to be in water, and the blood, of course, is made of water. Drugs with high volumes of distribution, they tend to have long terminal elimination half-lives, but shorter durations of action. Some drugs with relatively low volumes of distribution have long terminal elimination half-lives, but short durations of action. It's a very complex issue, and it takes a little bit of homework by either the prescriber or I'm going to get to the legal system in a second to understand this. So, why is it important? Well, some practitioners will just automatically assume that a drug with a long half life needs less frequent dosing. Uh, it's assumed that it's easier, say, to taper off drugs with terminal elimination half lives that are long. If the drug has a short duration of action, that might not be true. And one example is a woman named Heather Ashton. Ashton, God bless her. She was one of the first people to call out the terrible withdrawal effects associated with benzodiazepines. That benzodiazepines have a very bad withdrawal syndrome associated with it, and she wrote the first sort of Bible on this and helped a lot of people. She passed away not too long ago, but a very saintly woman who cared a lot about people. But one thing she did is she recommended Valium as the drug to taper people off with. Now, I understand why there's active metabolites, but the active metabolites of diazepam, they do the same thing sort of the diazepam itself does. They're lipophilic as well. They distribute into the tissue, and then they're in like an equilibrium with the blood. So they're in, they do their work at the central nervous system. Then there's a rapid pull down, and then they slowly sort of come down over a long period of time. Nordiazepam, which is a metabolite of diazepam, has a half life of up to 100 hours. So there's a rule of thumb that 5 half lives are necessary for a drug to be cleared from your system. So that's 500 hours. That's quite some time. Uh, One of the things outside of the medical profession is that people are at risk for DUIs if they took a drug with a long terminal elimination half life. If there's say a blood draw, say, and I'll go to the next slide for this because there are examples of individuals being charged with DUIs because they received a single dose of diazepam several weeks before they're pulled over because they were taking an MRI. It's anybody who's had an MRI knows it's kind of claustrophobic in there, and some people kind of freak out. So doctors will often give a single dose of diazepam, lorazepam, one of the benzos, but diazepam's still a common one. Maybe they should move away from that because of the issues that I'm about to discuss. But you can have somebody, a little old lady who gets an MRI. She takes a single dose of diazepam, and then 2 to 3 weeks later, she's involved in a little fender bender. She looks a little unsteady on her feet. The cop wants to get a DUI. He's behind on his quota. I don't know if there actually are quotas, but so there's a blood draw, and they find low levels of diazepam in there after several weeks, and this person ends up getting charged with a DUI. These are the cases that need to be challenged, and oftentimes DUI lawyers they don't really challenge these cases, but with the information that I'm giving in this presentation, they should because uh, it's been said that, and I've known that a single blood draw by itself doesn't tell you anything. You need to know how long ago the person took the drug. You need to know if the person has any uh, hepatic dysfunction where there's trouble clearing the drug from the system. You need to know what the terminal elimination half life of that drug is, and you need to know what the duration of action is, and you should know what the minimum concentration uh, it is to exert a therapeutic effect. So all of those things come into play, and this underlines the concept that a single blood level of a drug should not be relied upon to be determined to to tell if a person is affected by that drug. Okay, keep going.